Well, welcome everyone to today's webinar. We are very excited to have the opportunity to share some reflections with you on this really important topic. So before we get started, firstly, I wanted to run through some housekeeping. So firstly, this session is being recorded. The recording will be shared in the coming weeks on the Global Health Network platform and the Connect site, so you can share materials with others. The link for the site will be shared in the chat box for you. This webinar is being held in English to automatically translate the speech to subtitles in your chosen language. Navigate to the closed caption function and you can select your language. Due to the number of participants, your video and microphone has been disabled. So please use the chat function to introduce yourself or to report any technical issues. The Global Health Network team will assist you with these. Please use the Q&A function to post any questions and comments through the webinar, and you may do so anonymously if you wish. We have dedicated some time towards the end for a Q&A, so we'll try to get through as many questions as possible. And if we don't have time for all of your questions, we will compile and address them after the session, and they will also be available on the Connect website after the webinar. So before we head into our webinar, we invite you all to complete a poll, which should be on the screen now. We have 2 questions for you. These questions will give us an indication about your experiences and also your experiences in relation to grief within workplaces, and also any supports that you have received. So we'd value if you could take just a few minutes at the moment to answer these questions. So have you had any experience in dealing with death and dying in your workplace is the first question. And it sounds like quite a high percentage of you have. And we're grateful to hear from you later on in the Q&A session too, if it's any particular issues that have arisen within those experiences. And our second question, have you had any support or training in reflecting on and processing such incidents? If you could answer that, and if you could also just take some time to just give us a little bit more information in that poll, that would be greatly received. So thank you for that. So while you're completing the poll, we might just share, we've got people joining us, I can see, from so many parts of the world, and it's wonderful to see that people are working in various contexts that are relevant to this issue. So could we perhaps share where people are from? We've had over 400 people register this evening, so we are hopeful that most of those will be able to join and share some of their learnings as well. So today's webinar, Grief Within Neonatal Care Contexts, Perspectives of Mothers and Health Workers in Kenya. This event is brought to you by the Global Health Network and its Knowledge Hub Connect, which is a hub for health workers and field workers involved in research. I'm Jaom Fisher, and I'm the coordinator of the Connect website, and I'm really delighted today to be joined by our wonderful speakers. We have 3 speakers with us today. Mwanamvua Boga, who's a paediatric nurse manager and lead trainer from the Kenya Medical Research Institute Wellcome Trust Research Program, also known as KEMRI, in Kilifi in Kenya. We have Dr. Dorothy Oluoch, Post-doctoral Research Fellow also at KEMRI, the Kenya Medical Research Institute Wellcome Trust Research Program, and Joan Baswetty, Senior Nurse with the Newborns Unit at Kenyatta National Hospital, Nairobi, and also the support of the Global Health Network team. Grief is an intense sorrow. It presents most significantly at the loss of a loved one. It is experienced by all of us, and the intensity of grief is heightened for a parent at the unexpected loss of a baby, often arousing emotions of profound sadness, confusion, shame, guilt, and anger. The birth of a child is an anticipated joy and time of beginnings, of future potentials and relationships. The unexpected and traumatic loss of a baby significantly impacts the patient's emotional and physical well-being, their health outcomes, perspectives on their future and their relationships, and their experience of the health system. But the impact of grief is not isolated to just the patient or the parent. The impact on health professionals, their stress levels, their own emotional well-being, and their work capacities, as well as the broader healthcare system and environment, is also significant and requires attention. In today's webinar, we will focus on the context in Kenya. We'll explore the day-to-day challenges for nurses in dealing with death and dying in the newborn unit, the emotional burden for nurses doing this work and for mothers experiencing the grief of losing their babies, the supports needed for nurses and other health practitioners to learn to handle death respectfully, and the support needed by the mothers who have just lost their babies. This webinar session will last an hour and a half, and we have 3 experienced speakers, and we will allow plenty of time also for questions and answers. So we'll begin today by introducing you to our first speaker of the session. Mwanamvua Boga is a paediatric nurse manager, researcher and lead trainer on communication skills and emotional competence for health providers at Kemri in Kilifi. She has over 20 years of hands-on experience in acute paediatric and neonatal nursing and clinical research practice at the Kilifi County Hospital. Her work includes care of critically ill children, nursing management, administration responsibilities, and capacity building. And over the last 15 years, she's extensively been involved in training health providers and research staff on communication skills and emotional management, using reflective practice and experience-based learning methods. Her commitment to strengthening respectful care and professional wellbeing amongst health professionals has seen her train over 500 health professionals, researchers, and managers, and present her work at several national and international conferences. So we invite Mwana, who will begin our webinar by introducing the context of the grief experience within neonatal care units here in Kenya. Thank you. Thank you, Mwana.
Okay, thank you, Jaom, for that excellent introduction. I feel like an expert here. Yeah, so can we have the slider? Yeah, so let me just show you where I work so that you can understand the context of how we work with our mothers in our day-to-day unit. So I work in a high dependence pediatric research unit. And this is our acute room where we take care of critically ill babies, very, very sick babies. And death happens so often in here. And as you can see, the place is quite very small and very congested with lots of mothers, but this is where we deliver our care for the critically ill. And here, this is me talking to a mother who had a very, very sick child on this day. And I know most of you can relate to these settings, especially those from poor resource countries. They can relate to how the context in where we nurse these very critically ill babies. But at the end of the day, we still do very good work. So I just wanted you to have a look or to see exactly where I work in practice. Okay, so the next. So now I want to share a case study that we will use as a reference point for our webinar throughout the discussion. This webinar, we will use this case. So on the screen is a summary of the case, but I will read through the case so that you can listen in. So this is a story of a mother who lost her baby boy in the newborn unit, in one of the newborn unit, not specifically mine. So Jen from the rural village is pregnant with her 4th child. She had a smooth pregnancy. However, her labor lasted longer than expected, and a natural delivery at the local dispensary became impossible. As she struggled in pain, The nurse shouted at her, calling her uncooperative and warning her that if she doesn't cooperate to push the baby, she will go home with her dead baby in a box. Eventually, after it was clear that the additional assistance was needed, Jane was referred to the sub-county hospital for an emergency operation due to obstructed labor. However, the ambulance took 2 hours to arrive at the dispensary to transport this mother to the next level of care. At the sub-county hospital, Jane's cesarean section was further delayed because the operating theater was in use with another patient. After 1 hour of waiting, Jane delivered a baby boy via cesarean section. Although she was relieved that her baby was alive, the doctor informed her that the baby did not cry at birth and needed specialized care. So Jane and her newborn baby were then referred to the county hospital for specialized neonatal care. So this mother is from the dispensary to the second level of care, and now she's being transferred to the third level of care. So the baby had difficult breathing and remained on oxygen for 3 days. A chest X-ray was scheduled for the baby, but it was not done, and no explanation was provided to the mother. Blood samples were taken, but Jane received no feedback about the results. On the third night at the hospital, the baby's condition worsened. Jane sought help, but the nurse, overwhelmed by a ward with over 30 babies working alone, reassured her that the baby was already receiving medication. Exhausted, Jane fell asleep by her baby's bedside, and she woke up to find her baby not breathing. Jane immediately alerted the night nurse, who attempted resuscitation, but it was unsuccessful. The on-call clinician, an intern doctor, was called, who came to examine the baby and finally said, "Time of death, it's over, the baby is gone," and quickly rushed out of the room. He left the mother crying, inconsolable and in shock, watched by a congested room full of other mothers. Devastated by the loss of her only son, Jane was overcome with anger, sadness, regret. She blamed the nurses, the doctors, believing more could have been done to save her baby. In her grief, she recalled how the nurse at the dispensary talked to her rudely while she was in labor. She recalled the warnings from her fellow mothers in the village about the dangers of giving birth in a hospital and regretted her decision to seek care there. The nurse feels sad for the mother and the loss of the baby and feels angry with the clinician who left her alone to deal with the traumatic situation. She does not know how to support the mother who sits by her dead baby, crying and in distraught. She quickly wraps the baby and takes it to another room, saying as she leaves, "Sorry, Mama, God will give you another one." So this is our case. And I just want us to take 1 minute to reflect over this case. And my question is, how does this story make you feel as a nurse, as a midwife, as a doctor, as an administrator? How does this story make you feel? And what are some of the reasons health workers act this way? So we saw the nurse at the dispensary level, the nurse in the newborn unit, the intern doctor. All of them behaved differently. But my question is, what are some of the reasons health workers act this way? So put your comments on the chat as we move on. But we will use this case as a reference throughout our discussion. So let's move on. So in our daily work in the newborn unit, babies die, my parents grieve, and often we lack skills to handle our own emotions, our patient's emotions. As you can see, we have limited staffing. We are working in very limited spaces. Very congestion is the order of the day. And then we have the culture of blame. Sometimes deaths happen, but we get managers fault finding. What happened? What didn't you do this? Why did you do this? So the emotional burden in these units is quite very high. As you could see from the case, this nurse was all alone with 30 babies. Several babies die, not one, not two. Sometimes you can lose even 3 babies in one shift, and somebody is working alone. So parents grieve with no support, no private space even to sit with them in a comfortable manner and talk to them. And above all, we have no training on how to handle our own emotions as carers and the emotions of our patients. And also no debrief for staff after the babies die. As you can see, even in the story I've shared, this nurse had to continue because she was on shift and she had to continue working. So we will come back to this point later in the discussion. But for now, I hand over to Dorothy just to give us the context of mothers' experiences of care in these settings.
Thank you, Mwana. So I'll just introduce Dorothy to you all. Dr. Dorothy Oluoch is a postdoctoral research fellow at Kenya Medical Research Institute Wellcome Trust program in Kilifi. Her research interests include patient and staff experiences of illness and healthcare and experience-based co-design, maternal, newborn and child health, research ethics and evaluation of health systems interventions. She currently leads studies on the experiences of families and health staff of preterm birth and neonatal care in hospitals. Dorothy will share about the Kenyan neonatal care context, the mortality rates, and the grief experience of mothers. Thank you. Thank you, Dorothy.
Thank you, Joan, for that introduction. So I shift a bit now to start talking about what does it mean for a mom to have your baby admitted in the newborn unit? And what does it mean, not just for the particular mom whose baby has died, but also for the other mothers on the neonatal wards when there's a loss of a baby? Okay. So looking at the pediatric admissions and mortalities across Kenyan public hospitals, babies aged between 0 to 28 days account for majority of the admissions and mortalities within this age group. Over the years, we've been conducting qualitative work within newborn units in Kenya, primarily conducting long hours of ethnographic observations within the newborn units, but also conducting narrative interviews with the mothers just to understand from them how do they experience life in the newborn unit, what are their challenges, and how do they cope being in this emotionally challenging environment. And several contextual factors and care practice norms emerge that shape the experiences and lives within the newborn unit. So firstly, with the admission of a baby in the newborn unit, the mothers within our public hospitals stay in the hospital during the admission period, which can range from 1 week to over 2 months. And this is very challenging because it's a shock to their lifestyles. They have to stop their daily chores at home. They worry about having to stop their productive roles. And this also introduces financial shocks for the mom and the families, adding another layer of worries on top of the emotional environment where they are in. The previous speaker has alluded to the structural challenges within the newborn units. So starting with the space limitations. Many a times, mothers whose babies are admitted in the newborn units are separated from their babies. And this is because they are admitted to the postnatal wards, which is outside the newborn unit. And they only come in every 3 hours to feed their babies. There's also high admission rates. And what this means is babies would share incubators. And for the moms in the postnatal wards, they also share beds within the postnatal wards. And this is quite challenging in terms of mother's comfort, but also in a situation where a baby dies and they had been sharing an incubator with other babies. It also affects the mothers in the event of a mortality. But in the context of this challenging environment, one positive thing that we observe emerging is the peer-to-peer support from the mothers. And this is quite useful in terms of one, learning about how to care for the babies, what is expected of you as a mom, but also drawing some psychosocial support and the feeling of togetherness in light of these challenging situations. Next slide, please. For many of these mothers, admission of a baby to the newborn unit often comes as a shock. Many times the expectation for women is that they would have a safe delivery and go home after a few days with their babies, but this is not the case in the event of a complication. And there's a lot of emotional distress for these moms. And firstly, one, due to the challenging environment within they're caring for their babies, but secondly, also because on a daily basis, they're observing deaths within the newborn units, and this is quite traumatic for the moms. Because of the understaffing within our newborn units, what we are seeing is a lot of task shifting in practice, where mothers are taking up roles such as feeding of their babies, including NG2 feeding, diaper change, amongst other tasks. And this is often done with limited support and preparation. And a part of coping mechanism for the moms is learning from each other. But there's also limited access to psychosocial support and also inadequacies in communication, which also contribute to this emotional distress, worries, fears, and anxieties for the moms within the newborn unit. So I'll just read one of the quotes from the moms. So she says, the days in the newborn unit are long, but what can you do? You just have to be courageous, because you can wake up one day and find that a child who has been with you in the ward, a child of someone you have been with in the ward, you wake up and find that the child has died. That makes you lose hope. You become stressed. So in the next slide, I'm going to project a short catalyst films of two moms talking about the experiences of dealing with grief in the newborn unit. Next slide.
Venye alikufa, sasa nikaambiwa usijaribu kulia sababu ule mwingine bado yuko. Sasa unajua kuna uchungu hapa, mtoto wako amekufa, unaambiwa usilie. Sasa mimi pia najaribu kujikaza nisilie. Lakini ni kama hiyo kitu inajaza kifua.
Know that thing is depressing. They should handle mothers with care. I'm sure kuna, especially maybe mwenye amekuja amelose mtoto wake, kuna mwenye ulikuwa unakuja unapata hata wakugoji, especially sorry to say, manase sometimes walikuwa na hiyo weakness. Mtoto wako ashapasi, maybe hiyo na hata hajafika kwenye kipita kujua. So wewe unakuja unapata, una imagine umekuja na diaper unaenda kuchini mtoto wako unapata hayuko. So unapata huyo mama amefaint, huyo mama nini. So they should be quick first before wakijua tu time parents imefika, kwanza ende loud and make sure the kids are okay. Ndio wakijua wako hayuko sawa wakuite before ufike hapo. Unaona hiyo cause itakutraumatize huyo mama mwenyewe na nyinyi wengine mnashare naye nikipita, cause obviously nikipita mnashare. Watoto hata ulikuwa shabod na kokanye cause mko wameshare na mtoto wako, so hata umeingiwa na hiyo fear. Umeona fulani ameenda na alikuwa na suffer the same disease na mtoto wako, what next? So wanastahili wakuwa wanaona ahead, wanakuwa wameondoa huyo mtoto ama kawa hata muondoa, at least kwanza wanaita mama yake wanamprepare instead ya jioni.
So from that short film, we see mothers verbally express the experiences with dealing with grief within the newborn unit. And you can see that through their choice of words, or the words that they're using. But you can also see the non-verbal communication, which is quite sad. And they also highlight issues to do with norms of care. For example, the mom was talking about at what point is the mom informed about the baby passing away? How is it done? How do we handle dead bodies on the ward? In a nutshell, grief is traumatizing and overwhelming for the mothers. Over to you, Mona.
Yeah, thank you, Dorothy. Yeah, I've watched this video many times, and every time I watch it is just a fresh experience. And I can see comments from the chats that it's very emotional. Yes, it is. It is quite very emotional, but this is what our mothers go through day in, day out with the not adequate support. So we have seen what the mothers experience. But now let's look at what is our own challenges as health workers when it comes to handling these mothers at this very difficult situation. What challenges do we face also? Yeah. So when if we're using to use, we're going to use the Jen's case as a reference point. So here is Jen. She has lost her baby in a very traumatic experience, and here she is. The baby is dead. So the thing that the biggest challenge that we have is, what do I tell this mother? What words do I use to comfort her? Because it's quite very, her joy has been turned upside down. So what words do I use as health worker to comfort her, for her to feel really comforted and to see that we as healthcare providers had the best intention for her? Is quite very difficult. And often when we ask health workers, what did you learn about handling death or death and dying in your medical nursing school? And they will tell you the thing that we learned is the stages of death. The stages of death, we all know them. They are health workers who are logged in here. And how to wrap the body, to do the last offices, and to make sure that the documentation is up to standard, because these deaths will be audited. But how to support the mothers, what to tell them, those are skills that we don't learn in our nursing and medical curriculum. It's there, but quite very limited. And then the other thing we also face as health workers working in these spaces, we have our own experiences of trauma. I've seen in the chat popping out that our own traumatic experience. So we are working in these spaces. Some of us have lost babies, some of us have lost our pregnancies, and here we are required to care for others. It is quite very challenging. So often when you're working with staff who had that kind of an experience in their life, it's quite very challenging for them to support other mothers, because anytime they are in front of this mother, they get triggered and they would say, I can't handle this. So the need to really understand each other is also very important. And then, so when we reflect on the case again, this nurse who was working in the newborn unit with the 30 babies all alone, and she needs to continue. She needs to hand over. She needs to hand over the babies and make sure that her documentation is up to standard. But often when nurses will tell you that we also need empathy. We also need empathy. We cannot pour from an empty cup. We also need to be empathized in this situation so that we can continue doing this very noble work. But again, we see that in our workspaces, the culture of blame is quite rampant, especially faulty finding or mistakes will happen. But how are these mistakes then corrected, and we learning from them so that we can improve in the way we handle things? So often you will see managers, what happened here? Why did you not do this? So it becomes very demotivating for staff. So staff will say, I wouldn't want a death to happen during my shift. And some will resuscitate the baby until they hand over to the next person. So those things happen. And above all, our own cultural beliefs. In many of our African cultures, talking about death is a taboo. Is a taboo because when you talk about it, it's like you're calling it to come. So we come into these spaces with these cultural beliefs. So even having engagements, these conversations with our mothers, it doesn't come that easy. So these challenges are here, and they really make us feel drained. The next slide. So these are examples from the training of from the nurses I train. And the one is saying, at times I feel so helpless and inadequate during a time of loss. It can be very draining. And I think from your chat, I also saw something like that popping up. We carry this with us. It's a burden. We have nowhere to vent, nowhere to debrief. We carry it with us until it happens again. We burn out. Blame from parents and management gets us down. When parents vent on us, we can't defend. We just wait for another day. So this is what we go through in our day-to-day work as newborn nurses, newborn care nurses. Next slide. So what are we doing about it? We as nurses who care for these babies who work in these spaces, what are we doing about it? So I just want to share about a training initiative that we are currently undertaking or implementing in Kenya to empower our health workers to communicate well with respect, with awareness, and emotional competence in this very difficult work situation. So this is the model we're using is called iCare Highland model, and it's action research on training using reflective learning and experience-based learning approach over time. And this is a model that was developed by Anna Halland. She's a social scientist from Norway, and I've worked with her for so many years, and we're still very great friends to date. So Anna, she's there in the picture. That's me with her. We were on a boat ride some times back. But this training has a very long history since 2006 when she started it. And it has so far been implemented in 9 countries in different contexts and different cultures. But here in Kenya, we started implementing this training since 2009. We presented the work about this training in our webinar last year in this platform, and all the resources about this training are available in the Connect website. So that is the website you can find the information about this training. Next slide. So just to briefly describe how the training approach is. So as I said, it's a 6 to 9 months training that uses reflective learning. And the aim is to build awareness of our own communication habits and the effect it has on patients and colleagues over time. And why 9 months? Why 6 to 9 months? Because behavior change is not an event. It is a process. You can't change your behavior over a day. It's a process. So the training is organized in 4 phases. So we have a phase 1, and the phase 1 is all about self-observation and reflection using guided reflective assignments around communication behaviors in your daily work with patients. So a good example of a task we give them is, how well do you listen to your patients? So for 1 week, just look at your listening behaviors with patients. When you listen well, what happens? When you don't listen well, what happens? And then we also give them another task around emotion. What irritates you when you are working with patients? Like this nurse from the dispensary who shouted. If the mother is not cooperating, I shout. Then what does that do to the care we give to the patient? So they get to become aware of their behaviors and the effect it has with patients. And then they share these reflections with us. And we use those reflections. We link those reflections into theory and practice using experience-based learning approaches, reflective practices, and the patient experiences that Dorothy has shared. So during the workshop, in the workshop, we bring the clinical area into class and we share the mother's experiences. We show them these videos. We bring the scenario of Jane into class and we say, these are the issues that we deal with day in, day out. How do we handle them? So we learn and incorporate their experiences into class to make the learning relevant to what they do on a daily basis. And then after the workshop, they go put the skills into practice. We follow them up with more tasks to ensure that they are practicing the skills as we would want them to do. And then after that, they come back for a follow-up workshop, and then we summarize the learning. So that's how the training is organized. And you can also find a description of the training in the Connect website. Next slide, please. So these are the modules we have. So the basic workshop, we have modules around communication skills, how to listen well, how to empathize with patients, how to ask good questions, how to read nonverbal cues from patients, handling emotions, understanding your own anger, your own emotions, understanding patients' emotions. So we have all these modules. And then in the workshop, in the follow-up workshop, we also have other modules so that we build on the learning. You can't learn all these things in one setting. So you build on the learning. And in the second workshop, this is where we learn about handling strong emotions like dealing with death, dealing with power, dealing with bullying, and dealing with burnout. So the death and dying, this is a module that we have developed over time. When we started the training, we didn't have this module. But from the reflections and the feedback from participants, we realized that this is a great need and we need to develop a module on it. So the module is about 3 hours to run it. It's quite very challenging to run this module because from my experience when I'm running this module, health workers struggle. They struggle. They cry in this module. We learn to support each other in this module because we realize some of us have lost babies and we have not gone through proper counseling. So when we are discussing all these emotions, they just come to surface, and it provides an opportunity for us also to support each other and see that how important it is then to support our mother. Okay, next slide. So just to show you how far we've come in terms of implementing this training on the neonatal care space. So we first had a training of nurse managers because nurse managers are critical in an intervention like this one. If you get a buy-in from the managers, then things can easily flow. So we had to train the nurse managers from 14 different hospitals. And then after that, we trained them as trainers. And then we supported them to roll out this training in their newborn units, 2 units, so that they can also learn how to train their own people. And then in our 4th stage, that's when now we incorporated the mother's experiences into the training modules. And that has really had a very great impact into the modules because we can see how our mothers experience care, what are they struggling with, the things that we make assumption that a mother can come into the unit and she can feed her baby. It's not like that. So they share that they are struggling with this, and we appreciate. So the patient experiences have been a very useful tool to incorporate. And then last year we got us a grant from Global Health Network to pilot this training as an online training and see is it feasible to run this training as an online training. So we did that, and we have great learnings from it and see how can we improve so that we can also use we can leverage on the online platform to roll out the training further to reach more health workers. Next slide. So just to share with you briefly the effects of this training on the neonatal units, what are the nurses saying after they've gone through that 9 months process? So we are seeing increased self-awareness and ability to recognize own emotions, patients' emotions, step back from reacting automatically to situations. They are saying we respect and see patients, see mothers as fellow human beings, that they are also part of the human race. Sometimes we feel like our patients don't belong to, they're not humans, but yes, they are humans and we need to see them that way. And then the other thing is they are now more sensitive in handling parents who have lost their babies, despite they working in these very challenging spaces, but they can now support mothers better. And then when they apply these skills, they see that they work, the skills are working better, and it strengthens their confidence to use the skills. They can now recognize that I have a burnout, because burnout is one of the modules we run, and prioritize self-care. And then majority of them, they're also seeing, they're role modeling these behaviors, and their colleagues see them, ask them for help. And the reason why we are saying this training works is the direct relevance the direct relevance, the direct relevance and applicability of the training to their daily work situations, and also the step-by-step learning over time in a safe space, in a safe space, building on different theories. So just to mention that when we have these the workshops, they function as the nurses feel safe to share their pain, to share their challenges without judgment. And often they would say after the training, they feel like they were in a therapeutic session. That's how many of them say so. Okay, next slide. Yeah, so the impact, so it does build sense of professional identity and strengthens our core values as nurses. And they also report greater job satisfaction despite these very heavy challenges. And of course, that awareness of your own emotions enables them to have reduced feelings of stress and burnout, because they can recognize when they're getting burnout, they recognize when they're stressed, and take care of themselves. And they also say they go home feeling they have done their best. When they talk well to patients appreciate them. They say, "Thank you, sister. God bless you." And those emotions are quite refilling to our own energies and motivation to continue doing this very noble but very difficult work. Next slide. So these are examples from the health workers on their perspective after the training with regards to handling death. So the mother told me, give me my baby to hold. And I gave her the baby. She looked at the baby, started calling the baby to wake up. I think before the training, I would not have known what to say. I think pre-training, if a mother told me to hand them their baby, their dead baby, I would hold back, because why would you want to hold a dead baby? So often they were very in a hurry to wrap the baby and take it away because we want to continue with our work. But now they're stepping back, allowing the mother time if they want to have time with their baby. The next slide. And then we're also seeing the role of managers in supporting staff to handle death better. So our in charge is very supportive of us. How she handles the issues about death in our unit, in some other words, the in charges can be on your neck. What did you do? What haven't you done? But our manager is so encouraging. She finds time to explain to us. We tell her what took place. She's our best support system. So this is quite very important. Okay. Next slide. So this is an output from the managers, from the course with the managers, with the nurse managers. It's available on Welcome Open. You can read and give us feedback. The next slide. Yeah, so these are also other outputs from the other stages of work that we have done, but they are still under publication. Next slide. Okay, over to you, Jaom.
Thank you for that, Mwana. Just briefly to remind people that please, if you have any questions that you want raised that the speakers didn't answer, please put it in the Q&A section as we're progressing through the webinar. So I want to introduce our third speaker. Joan Baswetty is a senior nurse with the Newborns Unit and a mentee trainer at the Kenyatta National Hospital in Nairobi. So we welcome Joan to share about her reflections on the health systems and grief.
Thank you very much, Jaom. And good morning, good afternoon, good evening to everyone. So allow me to share my lessons on the impact of grief on the healthcare professionals. To start with, we realize that healthcare workers often bear the heavy burden of grief while providing care. So you realize that whenever a mother loses a baby, it's the healthcare providers who are to break the bad news. It's never easy, and it's such a burden to the healthcare providers. grief management is an area which is quite sensitive, yet has little attention. Therefore, understanding the complexities of grief is very crucial. I know when it comes to grief, sometimes people might think it's only the parents who are affected, but also the doctors, the nurses, or any other person taking care of this specific baby. When we lose such a baby, it really affects us or affects the staffs. And it's important for us to have coping mechanisms to help the staffs in coping with the loss of this patient. This then means there's a dire need to have training in grief management to support the mother, the family, and staffs to promote emotional well-being. So from my practice, I've learned quite a number of challenges that we face when it comes to dealing with mothers who've lost their babies. One thing that I've learned is that there's fear. Some of my colleagues have really shared with me, they develop fear because they don't understand. How do we start breaking the bad news? How do we even start the process? They have the fear of what questions are these clients going to ask me? And of course, there's the likelihood of blame games. So probably the parents might start blaming the doctors for being part of the death of their loved one. The other challenge is lack of skills. So you realize that healthcare providers are trained to care and support the patients. Therefore, they find themselves suppress their emotions such that they have to remain strong to the mothers and even to the family. The other challenge again found is the reaction of the mother or the relatives who sometimes become annoyed. They're like, how do we, they can even beat you, you know. So sometimes there's the fear of how is this mother going to react to this loss of a dear one. So over time, we've had, from my personal experience, I will truly say this training has really, I'm so proud of this training because I have learned a lot personally. I have really improved in so many aspects, despite working in a busy facility. And of course, most of our institutions, you realize that we have shortage of staffs, which I think they mentioned, Dorothy mentioned that. So basically, we are very intentional when it comes to listening to our clients, despite the workload that we have. Then we are really using the skill of empathizing. So whenever we use, instead of us sympathizing with our clients, we are able to really, instead of sympathizing, we are able to empathize, support them, and even walk with them through that painful journey. Then personally, one aspect that I really love, or maybe I've come to really admire, is the awareness. I'm more aware of my emotional. Another skill that I, again, love, I love using, one of them is, the other one is stepping back, which is very key. You realize that sometimes when you're handling mothers who are angry and you find yourself, probably you're tempted to talk something that might even cause more trouble. So when I apply the skill of stepping back, I think I'll say it has really worked miracles, and I'm able to really readjust probably my comments. I'm able to get to know how best do I handle such a client. What about my colleagues? I've had, I've been able to share with my colleagues, and some changes that they have shared with me are, the effect of communication in the care. So you realize from the communication training, they are able to improve the care of their babies and even how to handle mothers who have lost their dear ones. They are more confident because of the skills, and they're able to use the skills of listening more to their clients. They're able to use the skills of asking questions. They're able to use the skills of stepping back, and of course, the skill of empathizing. Another change that I've seen from my colleagues is that they're eager to learn. They're eager to share their experiences. These basically, as they share the experiences, some of the experiences are the experiences before the training and even after the training. Like I remember there's a day we were on duty, and a colleague of mine was sharing an experience of how she applied the skill of stepping back when they were talking to a colleague whom really got angry and really talked badly, and she was like, do I talk or not? But I'm glad that she was able to use the skill of stepping back, and I really was happy to hear that from her. Then there's the recommendation that we get from my colleagues that the training should be done probably in the early stages before they start doing their rotations in the wards. And also, there's a recommendation to train all the staffs working in hospitals. You can imagine a scenario where mother has lost a baby. They've called the next of kin, and the next of kin is at the gate. They need to come into the hospital to support their dear one. So if this guard on the gate does not have the skills, then that means probably he or she may handle this client in a way that will probably bring trouble or cause more harm than good. But you can imagine if even the guard at the gate, they are trained on the skills of communication. If they find this next of kin, or maybe a father who has lost a loved one, then that means they're likely to support them and have them access their services very fast. So what has worked from my end? Some of the strategies that we have had is that the first one, from the case scenario that Mwana shared with us, you realize that the medical intern shared or broke the news and she left. She was done with her duties. But what is our key learning point? We have come to learn it's very important for us to have time with these mothers. If a mother loses a loved one, it's very important for us to be there for them, be present. You can stop all that you're doing and be there for them. Work with them in this painful journey. The other strategy we've learned again is the issue of, you realize most of our mothers sleep in their hostels or maybe in their postnatal wards. So the distance between the newborn unit and the postnatal wards is quite big, and it's very important for us to support these mothers. If the mother loses a baby, then we as the healthcare providers escort these mothers to their hostels or to the postnatal wards. We found this support system to these mothers. One other thing again that we are using is the supporting the mothers. In which way? You realize sometimes we have clients who don't have probably phones with them. They need to call the next of kin. So what do? We come in by helping to call the next of kin so that they are able to get the support system. And this therefore means what? We are embracing the family-centered care. So we basically involve the family in the care of, or maybe in handling such cases. Then the other strategy is the use of the communication skills, which I had mentioned earlier. We are listening more, we are asking questions to understand, we are able to empathize with our clients, and of course, learning the nonverbals and supporting these clients. Then there's another strategy again, which has really worked, miracles, the issue of teamwork. Mwana and Dorothy mentioned and said, we are working in a setup where we have too much workload. There's a lot of work, there's a shortage. And so you realize when a mother loses a loved one, this is a client who will require time. They need like full attention. So basically, how does our teamwork come in? So whenever we find a colleague having a mother who's lost a dear one, then what do? We come in, either you take up the roles that she or he was doing, or you can stand in and be there for this mother who has lost a dear one. The other thing again is that you realize nurses are all round. And sometimes having a nurse who is a counselor in the unit makes a big difference, because they really understand even the prognosis, they understand the disease process and all that. So basically you realize having a nurse who is a counselor working in a newborn unit can really do good to an institution or in a facility. So how are we working on the scaling up? So personally, we are working on having training for the multidisciplinary team. And of course, having sessions. We do have sessions with the doctors coming in for their first time in the unit. And we are planning to have induction for students and also new staffs. And of course, one thing that I've learned over time is that it's important for us to scale this training to the institutions, to the universities and colleges offering nursing and even medicine.
Joan, are you there? I think we've lost you for a minute. So thank you, Joan. That was, I think we might move on.
She's done.
That insight and the holistic look at how it's impacting not just the direct nursing staff, but also those other colleagues within the unit as well. Thank you to all of our speakers. We'd love to take an opportunity now to answer some questions, and I see that there are a few questions that have been raised throughout while you have been speaking. Firstly, one question we wanted to start with was, and please welcome to all three of you to respond to this. How do you adequately support a grieving mother when there might be others within the ward who have also perhaps lost their baby that day, or their baby is so critically ill you anticipate that they may not make it through the day? How do people instinctively support that within a busy unit where lots of emergencies are all happening at one time?
Yeah, can I? Yeah, okay. Thank you, Jaom. That's a very challenging question, and a very practical one, because that's what happens on a day-to-day basis in the unit. But I think one thing is just to be aware, having that awareness that I've lost a life here. And sometimes we as health workers, when a mother loses a 0.9 or a 1 kilo baby, because we've seen these deaths over time, we just become numb, and it's okay, but it's not okay. Because this 0.9 to this mother, this is a baby she was looking forward to have. So we need to have that awareness that we have lost a life here, and be present with the mother. And sometimes, we feel like supporting a mother, you need like an hour. No, it doesn't work that way. So being present, your attitude of kindness, your attitude of concern around that mother speaks volume. So being there, being present with her, listening to her. Majority of them, they have a lot of questions sometimes. So listening without defending yourself. Sometimes mistakes happen in the care we give, acknowledging where things went wrong, if at all they went wrong. Like in this case, in the case of Jen, that was quite a very painful experience. So empathizing with them, being aware, listening, answering their questions with sensitivity, being tolerant with them, because sometimes some of them really, I don't want to say they overreact, but every mother reacts differently to loss. So being tolerant with whatever reactions that the mother may throw out. And then one other thing that I also do in my unit, handling death is not a one-man show thing. It's not the nurses' work alone. It's not the doctor's work alone. It's a team, as Joanna said. And sometimes I may be so busy in a practical way. I need to support this mother, but another one here has arrested. I need to bag. So how do I support this one? So I usually even involve my own support staff, the housekeeping staff. They worked in these spaces. They know these mothers. They have relationship with them. So I call them, please come. Have time with this mother, talk to her, pray for her, and that has worked. That has worked really well for us and in my team. So it is difficult. I mean, it's challenging, but it is possible, and we just have to put that human face when we have lost a life, so that we can support our mothers better. Over to you.
Thank you for that, Mona.
Just one thing to also add is about the other mothers. Like in our case, Jen's case, you've seen the setup of our NBU. So when we have a death there, every mother is there. They see it, they become scared, and they become really worried. Something small they call, sister, come. This is not bubbling. The humidifier is not bubbling. The NG tube is out, but it's just the fear that they have because they feel the next is my child, or the next is my baby will die. So having that awareness that these mothers are scared, and just having a word of encouragement with them also is something very important, that we need to be intentional and say, we have lost a baby here. We are really sorry of what is happening. It can be very scary for all of us, but we are here to support you, and let's be hopeful that our baby will go home with our baby. So that's what I do. That's what I do practically to take care of the fears of these mothers. But I think it's their awareness that really makes a difference. Yeah, thank you. Over.
This is a comment that leads into a question, but generally neither the nursing staff nor the family circle often know what to do in situations of perinatal bereavement. Often we hide the baby from the mother. We tell her to forget that it's just a baby while she experiences deep pain. It's important to let the mother see her baby's body. It's even good for her to give him a name, to talk to him, to tell him that she loves him. It marks the grieving process and makes the grieving process easier later. And this leads into a question of how can hospitals integrate grief support into routine neonatal care despite resource constraints. You know, this is a suggestion of giving time for the mother with the baby to physically grieve and say goodbye, and how can that be integrated more intentionally into grief support in hospitals?
Yeah.
Should we invite Dorothy? Anything you'd like to say about that?
Yeah. I think just building on to what Mona has mentioned, I think that aspect of creating awareness and I find the use of these catalyst films quite powerful. So just using such approaches just to make it more, I think, putting that face that is experiencing that grief much more powerfully to the service providers. And I'm just reflecting in terms of what we've seen Joan's hospital do with the findings from our research on mothers' experiences. And I think just evoking those emotions. And what we've seen happening in that hospital is the importance of having a champion or somebody who's very passionate about maternal experiences, grief issues, and that as healthcare providers, is there something small that we can do for the mothers? Just the small gestures that that they do, as Man has alluded to, just sitting down with that mom just for a minute, also just holding her hand so that she sees that you also feel her pain is quite important. But I do agree, the context within nurses working within African settings, it's understaffing. The working conditions are not so favorable. So I think the big question still remains, how do we expect nurses to be able to do a lot more in terms of the support they offer to their moms? I think within institutions, having conversations and thinking around, okay, this is our situation, but what is that first step that we can take to reach the heights that we ultimately want to get to? So just starting small would be my response to that. Yeah.
Just to follow up on Dorothy about starting small, it's only that Joanne has disconnected from the call, but in their hospital, so they are working in the national hospital, and their newborn unit is quite very busy. They can have 120 babies at one point. So that's quite a very heavy workload. And so after their team went through this training, what they did is they selected one of their nurses who is a senior nurse experienced in the newborn care, and she has counseling training, and they gave her that role to support mothers. And they felt a counselor coming from the social work department may not really understand the context of the newborn unit and what mothers go through, as opposed to compared to a nurse who has lived these experiences and she has this counseling skill, she functions as a better counselor than a counselor from the social work department. So that is something that they have incorporated in their hospital, and it's small, but it's working. And again, I think the other thing that I also doing is the family conference. It's a new concept, but it's picking up slowly. So having family conference with these babies, for the family of these babies who have poor prognosis early enough, and walk with them. Walking the journey with them is also quite very important. I don't know whether I've answered the question. Yeah.
I just want to acknowledge too that there was a contribution made about a hospital where they've introduced a memory box workshop. So integrating with the social work team as well as the nursing team to actually have support groups where mothers are invited to attend and decorate and fill their box with significant items related to that baby, whether it's photos or scans or image things that represent the child that they've lost, and that those workshops are not open just to the mothers but also to the fathers and other family members as appropriate. So that sounds like a great initiative, and again, having someone who has a good working understanding of the complexities of working in the neonatal care unit. One of the other questions.
Yeah. Okay. Let's have the questions coming.
This is leading to our next question: is do the attending nurses actually undergo counselling after the loss of a child? Because for them, it's also a loss. It's a loss of a patient that they're caring for. Within your hospital context, within the broader context, is that available?
So in a majority of the hospital, that doesn't happen. In a majority of the government hospital, that doesn't happen. And if we can reflect on the case of Jen, the mother in our case, and this nurse working alone. After that death, she's all alone. She has nobody to talk to, and she has to move on. So often, what nurses do, before I talk on our own practice or in my hospital, what nurses do to help themselves is the informal debrief. sessions they have where they share among themselves. I had this case, it was quite very difficult, just venting out among themselves, and that helps them. So that's one strategy that they use. But formal debriefs, it's unheard of. So in my unit, I have my manager is very supportive of our well-being. So we have regular sessions as a team to talk about our work, and even at the team level, we sit down and say, okay, how has it been? Sometimes you have so many dates and you can see everybody is quite burnt out. So we sit down and reflect over after the handover meeting and say, okay, let's sit down. How has been the week for everybody? How are we coping with these dates? So everybody gets to vent, to talk. Oh no, this baby came like this. Just getting them to talk and talk and talk and talk. Say, okay, yeah. And then acknowledging that we are doing a good job. Babies will die on us. They will die, others will survive. So this is part of our work. It drains us, but we need to be aware, also celebrate the lives that we save, and encourage each other to self-care after these events. So I champion my nurses to take care of themselves. I ask them, what are you doing for yourself? What are you doing for yourself? So we encourage each other that we need to take care of ourselves, because we're in this profession for long, for 30 years before you retire. So you need to also take personal responsibility to care for your own self. But I think the need for regular debriefs for staff is something that we need to be intentional about. Yeah, over.
We have a question in relation to whether there's consideration, what are the challenges or insights there might be in regards to births and deaths of neonates occurring at home. Are either of you able to speak to that question? Because we've been talking predominantly in the context of a hospital setting, but what about situations where the child has actually died at home before they've got to the hospital?
Yeah. So here, I think we don't have a direct relationship with deaths happening in the community, apart from in our where we work, we have the disease surveillance system, and they do verbal autopsy in communities, in the villages. They go to collect data, so they get to learn who died, what happened. And I think this is a team that has undergone grief counseling, because when they go out there and they're interviewing a family member who has lost a loved one, these emotions become raw, and it was quite challenging for them. But I think majority of them, they underwent the grief counseling and also ability to refer when where need is. Yeah.
It's fantastic.
So I'll just add something from my perspective as a researcher. So we haven't done much in terms of doing this kind of work in the community level, but we are soon starting to do that. But from our current studies, what we've done is some follow-up visits to the moms post-discharge, just to track how mom and baby are doing post-discharge. And we've had few instances where we come across some of our participants losing their babies post-discharge. And also, just to add, also for us as researchers, it's quite traumatizing as well. So we also do have debrief sessions amongst ourselves, and of course with Mwanamvua and our team, giving us a lot of support on that end. But also just to quickly mention that I think a lot of birth complications in many communities come with some stigma attached to it, looking at the cause of death, preterm deliveries as well, which definitely also impacts on the mother's well-being and the kind of social support that she gets at the community level. So I think maybe in the next sort of webinar, once we've done a lot of work in the community to better understand that, we can be able to contribute a lot more to that space as well.
And as you said earlier too, the whole conversation around death too is, providing avenues for people to feel comfortable speaking about it more broadly in the community. Yeah. So there is also a question that's come up. How do you deal with death that occurs when you encounter parents of a child who have beliefs that their child should not be given injectable medicine because something evil has been thrown to their child and they've been warned by a traditionalist not to allow injectable drugs? As the medic, you're a crossroad between giving a life-saving intervention and respecting the rule of patient consent. How do we balance that? So I guess this is where, if there had been intervention, perhaps the child might have lived.
Yeah.
How do you and your team deal with those moral questions and challenges and the wishes of parents? Yeah.
Yeah, that's
big
a very interesting question. Yeah,
Yeah.
so these situations happen. They happen a lot because parents come in and they have their own beliefs. And just to share my own experience on how I handle these cases.
Mhm.
One thing is I listen. I listen to them, and I need to be respectful of the beliefs of the parents. But I need to work in a and have a consensus with the parents to see what is it that I can allow for them to do for their baby while in the hospital, and still be able to give the care that we think is important, but also respecting their beliefs. I can give you an example. I had a child who had severe malaria, had been in coma in the week for a week, and the parents suddenly they're saying, we want to take our child home because this sickness is not a hospital sickness. It's something, we have rituals that we need to go and perform. The baby is just here, is the body, but the spirit is not here. So we need to go home and have that spirit brought back. So that's a very complex thing. And the child is in coma, is on oxygen, can't go home. So I sat to the parents and said, okay, so what did the traditional healer say that he wants to do for this child? And I know from my experience in working with these communities, the traditional healer can heal somebody even who is abroad, is wherever miles away. They can still send their spirit there to heal the patient. So I sat down with the parents and we explored. So they said the traditional healer has a charm we want to tie on the child. He has some oils we want to apply on the baby, and we also have some herbs to put in the water to bathe the baby. So when I looked at these therapies, they are all harmless therapies. They don't interfere with our antibiotics, with our oxygen, with everything. So, I thought this is something that I can allow these parents to do without causing any conflict in our care. And I said, yeah, they're fine. Bring the charm. I'll assist you to put on the charm on your baby. And immediately they had all these things in their bag, and they brought them out. My sister, here is the charm. And I assisted. I put the charm. The oil said, okay, now just apply the oil, bathe the baby with that. And they were very happy. And they stayed. They agreed to stay and were able to complete the antibiotics. And the child did well and woke up and went home. So to the parents, they felt they also contributed and their beliefs were respected. So I think it's a matter of not being very, very hard that you can't do this, but exploring what is it that I can do that doesn't affect infection prevention. It doesn't affect the care I'm giving to this baby, and allow the parents respect their views. So that's what I do. I'm keen to listen to the parent and see what is it that I can compromise for them to remain in the hospital and the baby to get the right care that is needed. Yeah.
Just a brief final question. It's in relation to this focus on fault within a hospital setting. And so maybe Joan, you might be able to speak to this as how do you, what do you think is a way to address this a culture of fault where perhaps it's coming from management, managers within the health system who need to find what went wrong, who's to blame, you know, how do we answer people's questions? Is there a positive way of trying to respond to that, to also acknowledge the grief that's happening within the context alongside hospital requirements and perceptions?
Thank you. Thank you very much, Jaom. Personally, from my end, I'll say, truly speaking, the blaming is there. But one fact that is there is on a monthly basis, there's usually auditing that takes place. And auditing, again, is very important because auditing basically is a way of getting to know where the gaps were and what needs to be done and how better or maybe how to improve the care. So basically, I don't think if blaming will be there, yes. But again, I think we need to probably emphasize or train staff to just understand the issue of auditing that will come purely to improve the care of our patients. From the aspect of clients, I think that is something that cannot be really, we may not be in a position to control that. But of course, with respect and explanation, then they are able to really understand probably why they lost a baby. So for instance, as we are talking about family-centered care, it's very important, very key. And this basically can help in preparation. Just if the baby is quite sick, then when we have family-centered conferences, then this can help the parents to understand the baseline of how the condition of their baby is. Thank you. Over to you.
Thank you for that,
Yeah.
Joan. Look, there's been a number of comments saying, you know, yes, it's one thing to provide training and provide these skills, which are really, really important. But at the baseline, it's also the conditions in which the healthcare workers are working, where the ratio of patients to nursing staff is imbalanced. The resources and the extra capacities are really stretched. And how, you know, despite training, until the system recognises that, it's always going to be challenging within a grief context to fully give recognition to what has happened. So I just wanted to acknowledge that that's come from a number of our contributors here today, is that really systemically there needs to be a recognition that it's really tough working conditions that people are in, that you know, is added to by the grief context as well. Look, I know there's been lots of questions and we haven't been able to address all of them. Please continue to add to the Q&A if you have any additional questions or you haven't had a chance to actually raise your question yet. And we may not be able to get through those today, but we certainly will try and answer those and put them up later. I just wanted to say a big thank you. There's been some amazing questions and also responses and sharing in the chat of other ways that hospitals and medical facilities are trying to address this issue and provide support. And they all sound really fantastic initiatives. So thank you to everyone for sharing those. What I wanted to do just before we finish is give an opportunity for our three speakers to just briefly respond to one final question, and that is really, how do we ensure that our health systems support patients, families and health professionals in dealing with grief? Can you just briefly say, what do you think your key recommendation would be, and is it realistic? Is it doable within the current context?
Yeah, maybe I can go first.
Start,
So,
yeah,
so I
sure.
think, a lot has to change as the viewers have said that our health system is sick. Before before we do self-care for health workers, I think the health system itself has to self-care. Because if you reflect on the case we have shared, this nurse in the dispensary working alone, majority of our nurses in the dispensary, they work alone with a housekeeping staff. So she manages the labor room, she manages the NC, she manages the pharmacy, all that done by one person. It's unacceptable. It is totally too much. So the need for additional staffing, that needs to happen. I mean, that needs to improve. It has to improve. So right from the dispensary and even in the units where we work, one nurse managing 30 babies and expected to deliver quality care as per WHO standards, I think that's an impossible task. But we have nurses who are quite very passionate and they love what they do, but they need to be supported so that we can achieve the SDG goal that we all want to achieve. So the staffing has to improve. Managers have to take responsibility. And then I think the other thing is also the leadership style of our managers. They need to empathize with the people they work with. They need to empathize with the nurses they work with. We have nurses who are quite very dedicated, but sometimes how managers handle the staff that they manage can be very demotivating. So I think leadership practices also need to improve. Managers need to be trained. Majority of us as managers, we find ourselves in management positions without any training. You have just risen over the ranks with your experience, and here you are a manager with no skills, no experience, and you have been in a system where for you to be a manager, you have to be authoritative for things to work. So that's what we emulate, and that's what we move with, and that's what we use to manage people who are working at a very difficult situation. So it can be very demotivating. So we need managers also need to be trained on emotional intelligence, on communication skills, how to handle staff in a constructive way. Maybe just to give a brief thing that I do as a manager. If I walk in the ward in the morning and I want to receive report, I get an overview of how was the night, how many deaths have you had? We've had 2 deaths, 3 deaths. That already puts me. My awareness is already high on how I talk to these nurses. I'm mindful of what I ask, the questions I ask, encourage them and appreciate for the work that they have done, not to start fault finding. And even if there are mistakes, then how you handle those mistakes in a manner that is constructive for us to learn from those gaps and improve, but not to blame and fault find and criticize. It's quite very, it's quite very demotivating. Maybe I just give the other speakers a chance to also contribute.
Say anything, or Joan? Maybe Joan, you want to say something first?
From my end, basically, I'll say it's very important for us to have with the critically sick babies. It's important for us to have the conferences such that we involve the family in the care of these loved ones. The other thing is probably to have the healthcare system embrace the fact that debriefs are very important. It's very important for us it's important for us to take care of the healthcare workers, because they are the strong point or maybe the strength in a facility. So basically, it's good for them to have good mental health. So 2 things. Thank you. Over to you.
Thanks, Joan. Dorothy?
Yeah, also in support of John's suggestion of we need to encourage involvement of family. And the other thing is, it's not just about support within the hospital setting, but we also need to think from a system level. How do we encourage and build up long-term support and follow-up for moms and families who've lost a baby? Yeah.
Look, thank you to all three of you, to Mwana, to Joan, to Dorothy, for your honest insights, for your thoughtful reflections, for your experience and expertise over many years. I think this has been a really valuable discussion about the complexities and the impacts of grief within this context, in the neonatal care context, and the impacts on everyone, from the mothers seeking the care, medical care, to those health professionals providing the medical care, to the allied health and other service providers that are present there as well, experiencing it, to the families of the patients and the broader health system. And you've also all stressed the benefits of empathic and effective communication and understanding, and taking time to see the grief that people are experiencing, and to understand that process for both patients and for healthcare professionals. Just for those of you who are still on, if you're able to take a minute to just give us a little bit of feedback. Already we're hearing in comments of people making suggestions of other topic areas. As Dorothy said, we need to think about what happens when the families leave the hospital, and what is the ongoing care process for those that go back into the community. So if people have just a few minutes, please provide some feedback through the survey that's on the screen at the moment. Just to reiterate that this webinar is being recorded, and that it will be available soon on the Connect website for people to access, to share with others who may not have been able to join today, but might find it valuable also to listen to this conversation and to contribute to discussions within their own workplaces. So please do. Come visit the website. The iCare Harland resources are available also on the website in full, together with other additional support materials that give you an understanding of how they've been implemented and the benefits within people's work, as well as many other resources that are available through the Connect website. So thank you all very much for joining and attending today's webinar. It has been a really valuable conversation, and one that is just a starting point. Let's continue this important discussion. Thank you all for your participation, and we'll say goodbye. Thank you. Bye-bye.
Thank you so much.
Thank you.
Have a good evening. Good night for
Good
those who are
night.
going to sleep. See you next time.
Thank you.